with Brady Martz Insurance, and we are hosting USI Insurance Services today. So Brady Martz Insurance ourselves, we focus on individual life insurance, disability, long-term care, as well as corporate-owned solutions and executive compensation strategies. On the health insurance side, we have a strategic alliance with USI Insurance Services. You'll get to learn a little bit about them today and the importance of this alliance. And it really comes down to health insurance is an extremely complicated topic. It's a very hot topic in today's world with what we're talking about today, rising costs. So we're going to dive in with a lot of ideas. Know that, not one idea fits all. And ultimately, if it's something that you're interested in discussing further on a more intimate level, please reach out to either myself, Gary on this call, or your relationship manager at Brady Martz. So with that, I will turn it over to some introductions.
Very good. Thank you, Zach, for the introduction. So I'll start with myself. I'm Gary Dennison. I am a Senior Vice President in the Employee Benefits Consulting practice here at USI. Been in the industry for about 30 years and primarily focus on outstate, North and South Dakota, outstate Minnesota, really in that middle market, advising employers on latest trends, cost control techniques, everything that comes along the employee benefits world. So I'll be spearheading the presentation. I'll turn it over to Chase for a brief introduction, and then we'll dive in.
Perfect. Thanks, Gary. Happy to join everybody today. Chase Ambrosia with USI as well. I'm an employee benefits practice leader and work in conjunction with Gary and our other consultants. Been in the industry for about 18 years, so a lot of experience between Gary and myself, and excited to share some of this messaging to really help employers understand, what is causing the rising cost of healthcare, and solutions that we can help look at as we sort of navigate the future in unprecedented times.
Yeah, and then just a little bit about me and a couple housekeeping items. So I've been with Brady Martz for about a year and a half. I've been doing insurance inside of CPA firms for about 7-8 years and in the industry for 14. If a question pops up on a specific section, we are monitoring the chat box on your bottom right of your screen. Feel free to throw a question in there or gather some questions. As you see, we added 15 minutes towards the end of the webinar. That will be used for Q&A via the chat box. So you can either ask them as we're going or wait until the end. We are good either way. So with that, let's get this started.
All right. So just real quick, everybody on the call, just a little brief introduction to USI. So we are a large national benefits consulting firm. Across the nation, we have about 500,000 clients, $3 billion in revenue, and then multiple local offices as well. So Chase and I are out of the Twin Cities, and we have representatives all over the Midwest and upper Midwest, North and South Dakota, and Minnesota as well. So a little bit about USI. So jumping into the topic of today. So as we know, you can't turn on the news, read a newspaper. A lot of attention of late has been on healthcare costs, right? And what's driving them, what are the factors, and what things can be done, in this presentation to curtail the rising healthcare costs. So as you can see, the list here is really, it's the first few on here, the aging of our population, right? Our health. Our population is getting older. More people are retiring as the baby boom generation is reaching that age. And then the big one really is rising rates of chronic conditions, right? As we know, the U.S. is dropping in that area as far as, the rest of the world. But we're seeing a significant uptick of chronic conditions as well, and which leads into technology and pharmaceuticals, right? That the breakthroughs we're seeing with gene therapies, weight loss medications as well, is a significant driver in driving those healthcare costs up. And then some peripheral issues as well, inflation and labor as well, staff shortages, the market dynamics. There's a lot of consolidation with hospitals and clinics, particularly rural hospitals as well. We've seen they either go out of business or they don't have the capacity to treat those with the higher risk factors. Our fee for service model, right, is basically our system now is you go in and see a provider, then the fee is paid based on what they're going to provide. A lot of times there's over treatment of things, upcoding, those types of things that can curtail or cost more money in the system as well. And then really the big one as well is lack of transparency and choice. We're going to touch a little bit on that as well in our presentation. Is we really have a lack of transparency when we're seeing a provider, their outcomes and the cost of such as well. So, all these tied together is causing significant higher premiums, and again, putting financial strains not only on as us as a consumer, but as an employer as well. I think this last 2025, Chase and I have probably seen the renewals higher than we ever seen in our career.
Mm-hmm.
Sometimes 18%, 40%, 45%. So it's not uncommon for us to see, are going to continue to see as well, the higher premium spikes coming down the road.
Hey, Gary, quick question. And I know we'll dive in much more detail here, but aging, we can't control that lever. People are aging.
Yep.
What on here, what levers have you identified on things that you can control?
As far as the aging?
No, I'm just saying of these levers, aging being one, we can't control that one.
Yep.
What type of levers can we control with decision making?
Very good. Yeah, great question. So that kind of brings us into the list here of we would call strategies, right, that we can control when it comes to the healthcare costs. So, and really it's going to come down on the left-hand side, right? These are some easier, less disruptive levers that employers can pull that will help control costs, right? Medicare education is a big one. Being prepared for retirement, right? And we always focus on health wellness, but also that financial component as well to help people transition. Income-based contributions as well. We'll talk a little bit about that. But more specifically, when we get into companies that offer or have a little larger employee population, it's going to be some of these on the right side too, right? Incenting employee and spouses to maybe elect their own plan. And then also at the very end here as well, physician engagement is, we call engaging your primary care doctor. So these are really the levers that we're going to look at pulling that will that we can have somewhat control over when we look at these levers. And really, again, just a preface, the left side is really meant, the first five is really any size employer can adopt these with less disruption that we have found can have an impact on your healthcare costs. On the right side, starting with spousal incentive health reimbursement arrangement, those are going to be a little more in depth, a little more deeper dive, and from a disruption, employee change, these are going to be geared towards an employer with maybe 50 or more employees. They have experience-based renewals, and that when we implement these programs, we would see direct result in a reduction in your healthcare costs. Chase, anything you want to add?
Yeah, I think it's just important to realize the stuff on the left-hand side that kind of applies to all employers. If you don't have some of these strategies incorporated today, it certainly is something that you want to consider as you move forward, especially from an education standpoint with an aging population, the retirement financial readiness, your health is your wealth. So the more that you can prepare your employee population to be ready to retire, the more, cost effective those employees are going to be for you, especially when you're looking to replace them as well once they do retire. And then income-based contributions, we got a really good slide for that because this is something that, we use here at USI, and it helps with affordability as well as employers that maybe have highly compensated employees. And then the stuff on the right, again, it doesn't apply to everybody, but experience rated groups, there's a bucket for everyone here. And we're going to go kind of one by one with these strategies and help you understand if this bucket fits your mold. And if you have questions on it, that's why we're here to help and provide additional understanding.
Right. And we're going to run through relatively, there's a lot of issues on here, right? So, and afterwards as well, we'll send out a survey, but also the intent is if there's one or two or three of these that really resonate, we could do a follow-up webinar on more specifics, deeper dives in some of these solutions as well. So more to come. So we're going to start on the left-hand side. So Medicare education is really one element that we see sometimes employers maybe overlook it. And as you know, as an employer, you can't necessarily incent employees to jump on Medicare. There's rules regarding that as well. But with 11,000 baby boomers that are now retiring and turning age 65 every day, this is becoming more of a relevant strategy for employers. So really the idea is instituting some robust educational process with your folks that are entering that age or are already over age 65, where you have a resource that you can employ to help educate those employees of their options, right? And typically those are going to be for, the lower wage income brackets as well. They could technically go off of your health plan, right, at age 65 and get a much better financial arrangement, maybe even sometimes better coverage by going through Medicare versus your employer-sponsored plan. So win-win, and and if we look at health status, typically that age group too, they have more chronic conditions, as we talked about a little earlier, and they would then exit the plan. So from a claims experience part of it, you could see a reduction in healthcare costs, let alone the reduction in the premiums that you'd be funding if they were to stay on your group plan.
Yeah, another thing to think about with the Medicare education, a lot of employers, their employees may be confused about the benefit package or how insurance operates in a group setting. So Medicare is even more confusing. So it's a good thing to really put some resources in front of employees that are approaching that age so that there is a little bit more comfort and they can also sort of line up the timing, whether they're going to join Medicare when they turn 65 or wait until they truly retire after the age of 65. But the better they can tee it up and stage it, it's going to be a better transition for those employees, and they'll be grateful for the resources that you put forward for them to get the help and guidance.
Yep. Thank you, Chase. Okay, so this kind of ties in as well with retirement readiness. Again, since we have a large portion of our population, right, that is turning age 65, but also so it's a turning point as well for those that are considering retirement. So this is one that's really popped up in more recent years as well. So as an employer, do you have a robust strategy to help folks prepare during their working years for retirement and feel financially comfortable in that move into that last phase of their life? So we listed a few solutions out there. Again, really emphasizing a qualified high deductible plan with an HSA. Are they adequately funding? Or maybe you're doing a match to prepare those folks that can use those dollars in post-retirement. And again, the Medicare education, financial wellness, right, have you ever explored the idea of bringing a third-party provider that can provide financial wellness to your employees? And then in Zach's world as well, do you have key employees that you may want to design a deferred compensation plan, Social Security education, and then again, a very robust 401k engagement strategy as well. And tying all those in together to promote, the financial wellness of your employee population. So again, that they're comfortable retiring at age 65 and not maybe, waiting till 67, 68, or 70 to make that transition. And again, if those folks then are healthy, they jump off your health plan, and you can obviously, it'll affect your healthcare costs on a long-term basis as well.
Yeah,
You know,
couple
go ahead,
comments
Mark.
there, Gary, just from Brady Martz's perspective as an accounting firm and also a wealth firm, and obviously insurance, we're talking tax efficiency here, right? With HSA, tax efficient savings, financial wellness. When can I retire? When should I retire? Specifically on the deferred compensation side, we have seen a massive uptick in companies looking into deferred compensation for their key employees. A couple reasons: you can pick and choose who gets the deferred comp. You can also essentially put golden handcuffs on these deferred compensation plans to encourage this key person to stay. So those are really helping with not only recruiting, but retaining and ultimately rewarding key people. So very, very good strategy in a competitive employment market.
Yep. Okay.
For sure.
Moving on, income-based contributions. So again, this is one that a lot of employers haven't necessarily explored. And really the intent here is when you look at your contribution strategy, what you're charging your employees for their healthcare plan. Generally speaking, most employers set a flat rate or a percentage of the premiums you pass along to the employees. So another trend that we're seeing that can have an effect on healthcare costs as well is really that affordability issue. So, and the idea would be almost reverse discrimination, where we would say we're going to tie contributions to a band of income. So lower paid employees would pay a lesser amount for healthcare, and then your highly compensated, higher income earners, we would charge a higher percentage of the premium as well. So a couple things to keep in mind is that way you're also attracting maybe younger families that may ultimately waive coverage. So we're promoting, the healthier age groups into the health plan pool. Therefore, keeps your pool more healthy, and it can affect renewals down the road, but also brings in that affordability issue as well as, your employees that are in that lower income bracket aren't assessed, $200-300 a month for healthcare coverage, where we could stagger it where they would pay a lot lesser amount versus those that are in the higher income brackets. So again, something to consider when you're looking at, redistributing how you're charging the employees for their portion of the plan.
And something to think about too, from a visual perspective, it makes your employee benefit package look like it's a more fair offering when you're asking those that are highly compensated to contribute more for the insurance, and then those that are, let's say, middle or lower waged, again, having a lower contribution that is affordable to them. So it just looks as a more equal way to offer your benefits when you have a range of compensation within your company.
Yep. It's something USI actually put in place years ago as well, so we're accustomed to it, and again, seems to work very well for our teammates. Okay, next topic would be dependent eligibility. Again, not going to spend a lot of time on it, but it's one of those that we always like to bring up is, from a premium perspective, is particularly for employers that have larger employee populations, maybe have offices spread out. But again, kind of tying in that affordability issue, folks are looking for ways to have access to affordable healthcare coverage. So it's maybe, do you have any mechanism in place that can somehow audit or, just be aware of, do you have anybody that are covered on your healthcare plan that may not be eligible dependents, like an ex-spouse, they weren't alerted of a divorce, or ensuring dependents, children, for example, are not tied to the employee. So it's just letting everybody know that, if you have a process, or maybe you want to look at a process, during new hire or some type of an audit that you can put in place to just weed out if you have anybody that is not eligible for your healthcare plan.
This was a really big thing, sort of pre-ACA timeframe, where a lot of larger employers were doing dependent eligibility audits and, reaping the benefits of savings with how many individuals that they were able to catch that should have been on their insurance. So to Gary's point, typically it's going to be geared towards larger employers and those that may be multi-state. But where you see it most common is in that dependent space where they shouldn't be enrolled because they're not a legal dependent, or an ex-spouse, domestic partner, civil union type arrangement, where it wasn't reported to the employer, and somehow those dependents were able to stay on the insurance. And typically there's a reason why, because they need it. They're an unhealthier person, may have a condition going on. So don't let that be the driver of your cost if you don't have a tight way to manage your dependent eligibility for your group sponsored plan.
Okay, and then last but not least on this first section, want to touch a little bit on the PEO marketplace as well. So this typically would be designed for more of the smaller end employers. When you say small, maybe 100, 150, and less employer groups, but typically, 30, 40, 50 employees, or startups for that matter, that are looking for ways to, tap into economies of scale and have access to benefits that large organizations have. So we have seen an uptick in professional employer organizations where you're essentially going to outsource the functionality, the HR functions of your organization to a PEO. And in doing so, have access to a lot of times their national healthcare plans that they have in place that are going to offer robust health plans, and maybe at much more affordable cost than you would be, going out and trying to get it on your own as a smaller employer, and then reap the rewards of, all the compliance and all the payroll and all the other pieces that the PEO is going to offer. So again, seen an uptick in that in the marketplace as well. We do have a panel of PEO providers. This is just a sample in the marketplace. So, anyone out there that has even looked at or considered, there are multiple options. So again, just having a resource that can maybe do a side-by-side comparison of what, if any, of the PEOs might make sense to explore.
Yeah, the nice part about having a panel too is that a lot of these arrangements allow the benefits to be carved out if it didn't make sense to put the benefits with the PEO and their master plan. The other avenue too is, thinking the life cycle of your business. And let's say you were a newer business, you were a startup. PEOs make a lot of sense for startups because they don't have the bandwidth or the resources to outsource HR, payroll, all those different functions. But as your business grows and you hire on HR, or you outsource an HRIS system, that's when you can be helped and transitioned out of a PEO as well. So there could be a short lifespan, it could be a longer lifespan. You could be a smaller employer, you could be a larger employer, but there are certain points of time where a PEO may make sense, and that's why we strategically have a panel to help employers with that discovery and validation, and if it makes sense, can help place. Otherwise, can do the standalone benefits and help place those other avenues like HRIS and HR and so forth.
Very good. Okay, so now we are going to refocus, transition a little bit into levers or strategies that are a little more in depth. So maybe a little more disruption from an employee standpoint, and from an administrative standpoint. But these are going to be now strategies that we have over the course of the last few years implemented with clients that we have seen a significant reduction in some cases in healthcare costs. So we're going to start with a spousal incentive health reimbursement arrangement another word for we call a SIRA. And in essence, it's going to be thrown into that spousal coverage strategy category. So when you look at your claims, if you're a larger employer on the call, right, what we often find is spousals are the cost drivers with a healthcare plan. For whatever reason, we find that really across the board with all of our clients that spouses drive costs. So in the past, typically an employer could say, we're going to carve out offering spousal coverage completely, right? The ACA, the Affordable Care Act, does allow for employers not to offer coverage to spouses. Most do. Or they would charge a surcharge for those that have coverage available through their spouse and still want to come onto your plan. An employer would then surcharge them $100, $150 a month to come onto your corporate plan. The feedback or the cons, the surcharge, it's kind of a stick, right? It's kind of a negative, and culturally, a lot of employers haven't really liked that and are looking for other avenues to make those incentives. So what we are seeing, and again, this is just an example of a client, and from a claims distribution, right? This would be a sample. As you can see in the middle, this is a large employer where their spousals from a medical plan and from a pharmacy spend are outweighing, right, the employee. So, and again, this is a very typical arrangement we would see with our employer groups, right, where the spousals are driving, for many reasons, are driving claims for their group. The ultimately, right, so we have a dual eligibility problem. You have 30% of your enrolled employees may have health insurance options through their working spouse. Those households, again, represent about 40% of your total costs. And then obviously, as a family, they can experience significant cost of premiums and out-of-pocket expenses for them as a family. So what we are seeing and have implemented in the last couple of years is what we call the total care option. So instead of the stick, we do the carrot, right? And basically where the family wins is we, as the employer, would fund a HRA, health reimbursement arrangement, and pay for the expenses of the family if they're the opt into the spouse's insurance plan. So basically to have almost 100% cost coverage, and the client wins because you are going to cap your expenses at a much lower threshold, right? Like you're going to throw $8,000 or $10,000 into the HRA, then it would incent those folks to opt into that spousal plan. So it's lower costs for the employer and lower costs for the family. So again, it's a win-win situation. So how would that work? Is if the family enrolls in a spouse's or partner's plan, then the client, you, the corporation, would provide a health reimbursement arrangement for all eligible expenses under that other spouse's plan. So that could be your co-pays, your co-insurance, your deductibles, your premiums as well. And again, those are all tax advantaged as well. So there's no taxation to the employees and in their family. And any unused dollars would stay with you, the client, right? So if they didn't spend all those dollars in the HRA, then you haven't remunerated those expenses during the course of the year. So at the end of the day, what we're seeing here is if these incentives are put in place, on the left, the family wins because right now, without the total care option, they're going to pay all their premium and out-of-pocket expenses. If we put the total care option in place, you're going to be funding the HRA to fund those deductibles and out-of-pockets in a percentage of the premium. And so it's a win-win. Almost, to me, it's almost like a no-brainer for those families, particularly those that have high usage and high claims as well. So if those are dropping off the plan, you also have to look at long-term, they may be high claimants, right? And when they drop off of your health plan, then you're going to see a decrease in claims experience and have more favorable renewals in the future. So the client wins in the right example is a fully insured client, right? If you are averaging, let's say, $16,000 a year for paying for their health plan for a family, and at the bottom, if they had the total care option, you may fund $8,000, and this is just an example, $8,000 in the health reimbursement arrangement. You're spending eight potentially, right, if they spent it all, versus $16,000 paying on behalf of that fully insured premium. And the self-funded example is much broader because you're funding claims up to whatever your stop loss limit is. And we're just using $100,000 here as an example, as you may have a family that drops off that is also on your high claimant listing where they're incurring $100,000 or $200,000 of stop loss claims. You would, those would drop off the books as well if that family migrated into the spouse's plan. So again, versus that $8,000 that you're putting up in the HRA. Anything there, Chase, you want to add, or?
I think the big point, and like you said, Gary, you're dangling the carrot, not the stick. And so for employers that, consider this option, you want to look at your risk. So if you kind of remember one of the beginning slides, looking at some of those statistics, like what is your dependent population? How many spouses are your dependent mix? And then what is that driver of your healthcare utilization? And if you sort of meet those metrics, that's where looking at these CYBRA arrangements are going to make sense for you as an employer, whether you're fully insured or self-insured. And, this slide kind of lays out very well how it's a win-win for both the employer as well as the family, in a little investment in terms of that, total care option with the HRA can go a long ways. And I think Zach is kind of a good example for Brady Martz in terms of having this type of arrangement for himself.
Yep, my wife has a health insurance plan, and yeah, we decided to make the move. But yeah, very common, especially for folks, in their 30s and 40s.
Yep, very good. And again, it's more of the trend we're seeing with the spousal strategy. And I think as an employer too is, have you seen data right in your health plan as well, where your drivers are, and what percentage of spouses are jumping onto your plan, particularly if you have even lower contribution limits where you're maybe the employer of choice, right? People are jumping onto your health plan because of its attractiveness, where you can offer a third option or a second option when people go through open enrollment, where they could elect the total care option as just another alternate to your offerings. We just put an example in here, an enterprise commerce company that implemented the total care option HRA. You can see the financial impact. They moved almost 245,000 off of their books in premium. They projected they're going to fund about 80,500 in claims and reimbursements through the HRA. So the net savings was close to about $165,000 in just net savings to the employer by instituting the total care option. And at the bottom as well, you can see the employee savings as well, because they're getting majority, if not all, of their claims and premiums reimbursed. It's a very attractive proposition for them as well. By the way, too, we do have the chat open as well. So if anybody has questions, certainly shoot us through the chat as we're moving through the slides. So this is just a very large national organization with multiple thousand employees that also had implemented this plan as well over a 2-year period. And so we just wanted to give an example here as well. First year, typically through education, you might not see as much participation, but like anything else, over the course of year 2, year 3, when word travels, right, and people get accustomed to this option, we do normally see an uptick in those that would migrate over to the option. So what we're showing here is the risk mitigation, right? So when you're self-funded, you have that risk liability that's sitting out there on the books. So this organization was able to drop their total exposure from 174 million to 4.5 million by eliminating the 363 families that migrated into this plan and got them off of their books. And again, as you can see from the financial impact, 3.2 million in premium savings, and it resulted in about 2.5 million in net savings just from the premium aspect of it as well. And of course, the employees, you can see down at the bottom, some significant savings for those that elected that opportunity. Okay, next category. If folks don't
Perfect.
have questions.
Yeah, redirected healthcare is another one of those levers that, employers can pull, whether you are self-insured or fully insured. But if you're experience rated, it may be something to look at. People may think redirected healthcare, or what you may be familiar with, is, let's say, a narrow network or an ACO, an accountable care organization. But there are other models that have come out, and you can see on the screen here, we have a couple carrier options like Coop, that is through Blue Cross Blue Shield of Minnesota, Surest, which is a United Healthcare product, and then you have some vendor solutions like Simple Pay Health, Proximal, and Garner. And these levers can help redirect potential savings of up to 5 to 10%, if not a little bit more. And the whole idea is to get people to have services done at more cost-effective providers that have better outcomes, less readmissions, and potentially lower in cost as well. So you can potentially offer a richer benefit through some of these incentivizations, and we're going to walk through a couple. Surest and Proximal are going to be the two that we're going to highlight. So if you want to flip to the next slide, Gary, I don't know how many employers that are on the presentation or webinar today have heard of Surest, but it's been out for a while. It's something that launched here in Minnesota. Originally was called Bind and partnered up with a local TPA, got it to a point where United Healthcare invested into that product, bought it, and made it their own. And the whole point of it is to have better outcomes and lower cost of healthcare. So they're looking at things a little bit differently. So they're rating providers for efficientness, having fewer complications, and effectively addressing the member conditions. So when they're able to put that into practice and track these patterns, what it ends up creating for this high value episodic performance, it's lower cost. And to an employee that could be on a Surest plan, it's a lower copay. Otherwise, if you're in your traditional plan, it could still mean that employee has to meet their deductible and out-of-pocket expense for that knee surgery that they need to have, and they could have gone to a terrible provider that may not be cost-effective and has a terrible readmission rate. So putting in a benefit like Surest through a carrier or Proximal can help identify opportunities for employers to get better healthcare that is going to be more cost-effective for them as well as you as the employer. So in this example for Surest, you can see that there's ratings here for these different physicians. And the example is a knee pain example. So we have 5 different physicians here, and we're looking at the use of treatment, other factors, and then how that kind of falls into a Surest copay category. So if we look at the far right and look at that copay category, you can see lowest to highest. So physician A is going to be, that lowest copay for a member to use. Reason being, it looks like they have better statistics when it comes to treatment for knee pain. And then when you consider other factors, their patient risk score is better. They're also average knee cost is a lot more cost effective as well. When you compare that to, let's say, physician E at the very bottom, we can see that they are higher in some of these categories, not as well rated, potentially, have a lower patient risk score. But when you look at locations as well as physician average knee cost, they may be lower, but when we look at the average cost for the knee pain, it ends up being on the higher end because of how they're having to treat and service that individual even before or post-surgery. So Surest is a really good example to help steer employees to going to better providers that are going to have better outcomes for them, but also keep them in a more affordable arrangement. And how that kind of plays out is into the plan design. So if you go to the next slide, Gary.
Yep, I can just get
sorry.
point in here as well too, is what's interesting when I look at this as well. If you look at physician A, they went through a treatment pattern, right? And to look at knee surgery, they averaged 8%, where in physician E, right, they jumped right to surgery for the most part, right? Or jumped right to pain management, meds, is far as not going through typical treatment patterns from physician A. So it's just interesting, and we do see that, right? That those that do alternate means of treatment before jumping right into surgery can have a significant impact. So
Yeah, that's a good point. Same thing with where the surgery is going to be located. So when you think about orthopedic surgeries, a lot of these major providers now have an outpatient surgery center where they're bundling in some of these services to make it more cost effective versus having it in an outpatient setting or a hospital setting where there are going to be additional cost outside of what that surgery is going to be as an expense itself. When you look at the concept of this plan design, if you look at the far right, this is kind of how Surest is laid out. Their MO is that they don't have deductibles or co-insurance. So to a member, essentially you're paying co-pays for all your services. So when you look at office visits, whether it's primary care or specialist, you can see that that ranges from $15 to $100. Obviously, if you go to a provider that costs $100, they're not going to be as highly rated as a lower cost provider that may only be $15. You can see that there's copays for urgent care as well as emergency rooms. But then when you get into some of those other range categories like imaging, procedures, and then your overall out of pocket, that's kind of how this model plays for a member in keeping their costs down, but also trying to direct them to more cost-effective providers.
right, and MRIs are always a good example as well, right? So if your
Yep.
doctor wants to order an MRI, typically speaking, most on this webinar probably have an open access healthcare system, right? You can go anywhere you want in the network, right? And versus where your primary care doctor might say, we want to send you to, the hospital to get your MRI. And there are significant cost differences between the same machine, right, versus the setting that it's in. And so that's where they tie that into the copay arrangement, as well as with some transparency to let you know that, hey, you're going to get the same results, but there might be a different facility you want to seek out that imaging and save you, the amount of money in your copay.
The other example that we wanted to highlight is Proximal, and we've had a lot of success with this benefit, have introduced it to the carriers as well, and actually saw one of the carriers here in Minnesota that also plays in the Dakotas include this on their commercial insurance. So we know that this is effective based on clients that we've seen move forward with it. But then the fact too that we also have a major carrier in the Minnesota market that has added this to their commercial insurance for members that are on their health plans. When you think about life-changing decisions, choosing a specialist can be very difficult. So a lot of people don't have the right guidance. So being able to provide that guidance and a little incentive can really, be a win-win for the employer as well as that member. Typically, these categories are going to be 60% of an employer's spend. So whether it's in hospitalization settings or specified illnesses or pregnancies, these can drive your spend as well as the trend of your health plan. And typically is going to be a lower percentage of your members. Like I said, equate to 60% of your spend, could be up to 75% of your trend. And then if you are a self-insured employer, most of these members are going to fall into 90% of your stop loss usage in terms of those that went over your spec deductible.
Just a quick question. Is there any overlap when doing these type of programs with potential help already? Just curiosity question.
So the Proximal, why we have had a lot of success with it. It's agnostic to the carrier, right? So this is something we would layer in on top of any health plan. So we don't have to, maybe like with the Surest model, you as an employer, we'd have to move to United Healthcare or their Surest product in order to incorporate that in, to the benefit offerings. So with the Proximal, there's no disruption, right? This is going to be a benefit, and think of Surest, it's the same concept, it's the same data that goes into the redirection of healthcare, right? So what we're trying to do is navigate your employee population, the top 20% of the providers, that are in the marketplace, and to treat, one of these ailments, maternity oncology, surgery, knee surgeries. And what this does is it does it through a direct reimbursement of $1,500 would be paid to the patient or employee that was redirected into the top 20%. So it's something that comes up quite a bit. So we don't necessarily have to move to Blue Cross Blue Shield or Surest to get the same economic benefit. And quite frankly, a lot of times it's a lot easier for employees to kind of understand it. It's first dollar coverage that they would get if they're exercising, being redirected.
And like kind of works with any health plan arrangement that you have, but I think one of the key things as well is that you're still giving employees choice. So they just need to choose a top 20%, choose a provider in the top 20% in their network. And that is going to, allow them to tap into this benefit, which again, kind of has built-in ROI just based on redirecting that member to a more cost-effective provider that has better outcomes. You're going to save as well as, essentially win on the situation.
Yep. And then again, how it works, right? And this is true whether it be proximal, even back to the Surest model, right? There's the technology involved is very robust. So you can go online or you go on an app that basically will then show you who the top 20% of the providers are in your geographic area. And then it gives you a background of the physician, their credentials, their outcomes, a bio on that surgeon as well. And again, this is just an example of how that would look. And again, in this model, it's paying a direct reimbursement of $1,500 to the patient that is going to be redirected to that high performing provider. And then we have a case study as well. So this is musculoskeletal hospitalization. And again, as you can see, and a lot of times too on musculoskeletal, it is the location of where they're performing the surgery. Is it an inpatient provider that is attached to the clinic, orthopedic, or are they renting the space at a hospital? And then again, outcomes based as well, whether readmission rates, et cetera. But again, this gives you an example of a case where it was $18,000, almost $19,000 of costs associated with that musculoskeletal hospitalization versus the top would be at almost $50,000 as well. So again, just to show where that savings is going to come in. And this one is an example, right? So we took a city that we work with, and we wanted to show in 2024, when they implemented Proximal, how they fared as far as those that were directed. So you can see at the top, they have close to 600 employees. Those that were
Looks like Gary might have froze for a second. So I'll continue on with kind of what he was messaging. Essentially, this does typically get a higher adoption rate. So you can see for the example, the total employees, but those that engaged were at 62%, and then those that actually logged in were at 50%. And we lost the presentation because Gary was presenting. I believe Margaret has a backup. Oh, there we go.
we're back.
We're back. You just need to reshare the presentation, Gary.
Sure.
And then I kind of continued where you left off. So just kind of finish up the example and then kind of go into, how this, I guess, stretches across multiple industries in terms of effectiveness.
Sure. Are we back?
Yes. Now we can see your screen.
Perfect. All right. Okay. Sorry, I wasn't advancing. So again, so what we're seeing just as a whole across all industries, the return on the investment by, again, installing Proximal has been pretty robust. Again, all industries that we have implemented Proximal. And as Chase has mentioned as well is we've had this relationship with Proximal for a number of years. And one of the major providers in the health insurance space has incorporated Proximal into their product offering as well. So it's a testament that they also agree that it does have an impact, it does work. And I think we're going to see more of this in the coming years as well, adopted into the health plan offerings. So at the end of it, really, they're all good, right? So whether it's carrier-based, whether it's proximal, but when we compare the two, where proximal sometimes can be a little more useful is we don't have to change carriers. You don't have to change carriers to, United Healthcare or Blue Cross of Minnesota. Proximal can be layered on top of any health plan. So if you're with Blue Cross Blue Shield of North Dakota or Health Partners or Sanford, proximal can be layered on top of really any healthcare offering that you are currently utilizing without having to change carriers. And on the carrier side as well, some of them are not HSA compatible because of the first dollar coverage. So that can come into play as well. And that's not the case on the proximal side as well. We can layer it on top of any health plan offering, whether it be a traditional plan or an HSA plan. It meets the compliance of both. So, okay.
This is a big one.
This is a big one. Yep.
Yeah, alternative funding strategies are one of the, I think biggest categories that we feel like we can help educate employers in terms of understanding, their risk, but also how they can look for savings to help control cost. At the end of the day, savings is hard to achieve in a large portion when you can see costs go up every single year. So it's more about trying to control your cost and make sure you're in the right funding mechanism and you have transparent information in terms of, your data and how you're using it, but also how you're looking at different strategies to control that cost, whether it's an alternative funding analysis and gravitating to a new strategy, or making your current alternative funding strategy work better for you. If you go to the next slide, Gary, we kind of have laid out here, different models, and we feel like a lot of employers that may be on the presentation today, the webinar, they're familiar with fully insured, they're familiar with a bundled self-funded arrangement that would be with the Blue Cross Blue Shield of North Dakota or Minnesota or Sanford or Wellmark or United Healthcare. But we feel that, where things are directionally going is looking more into those unbundled arrangements and or captive arrangements and gaining more control over levers that you can incorporate into your health plan arrangement. When you are fully insured, you pay a set premium every month. You may have an open access network or a narrow network, but typically, that carrier is taking the risk. You're paying a premium for it, and you may not get as transparent information. Similarly, with bundled stop loss arrangements, you're using that carrier's obviously TPA as well as their stop loss insurance, their pharmacy benefit management. So areas that you could have control and maybe achieve some savings, but those are areas where they're trying to profit off of. So as we look at unbundled arrangements, that's where we're able to help employers gain more control, where they're choosing a TPA that aligns with their intent, their strategy, their benefit offering. But then you're also incorporating a pharmacy benefit manager that may allow you to get rebates or incorporate patient assistance programs to really help alleviate some of your high cost drug usage. And then when it comes to stop loss, using outside stop loss that may be more competitive or give you different guarantees, such as a rate cap or a no laser renewal, or give you the option for lasers, which may be more cost effective in taking a little bit additional risk on a high claimant. And then lastly, with the captive arrangements, obviously those are more geared towards level funded and more specifically self-insured employers. But we feel like this is going to be one of the largest growth strategies for employers that are in the fully insured space today. So when you think about employers that range from, let's say 50 to 200 employers, you probably have experienced some volatility with your fully insured renewals over the past 10 years. So we feel that employers want to get out of that roller coaster effect, gain more control, get more transparency, and captives are kind of what is driving that solution. So it allows smaller employers to go self-funded without taking on the full risk appetite of being self-insured, put you in a pool with other like-minded employers to alleviate some of your bad risk, But more importantly, with your most catastrophic risk, putting in a captive layer to help offset that within the captive pool so that it absorbs a little bit easier and isn't as impactful to you as an individual employer. So these are our solutions that we feel are continuing to gain traction, and really important to understand, the risk versus cost savings and where do you fall within this spectrum. And we want to help educate employers to understand, especially if they haven't had a lot of visibility to their claims experience. It really kind of starts with understanding your data. And then with that, what would make sense based on doing a look back and understanding what your risk is today, what would make sense in putting a multi-year strategy together. Gary, you want to add to, some of the context about our unbundled and captive arrangements?
So yeah, so really, the as you can see at the top too, right? A little more risk, but then the reward as well. So, but we do have, arrangements like on the bundled approach. It's going to be like your Blue Cross Blue Shield of North Dakota, like Chase had mentioned, and then we have unbundled arrangements as well, like with United Healthcare has a division called UMR, that's their TPA. That we would look at for options as well, unbundling, and we have the ability to bring in prescription benefit managers, outside stop loss as well. And then on the captives, we have a couple options there as well that we work with. A big one is called the Pareto captive that we can look at, exploring for an option as we look at these various options as well.
Risk reward. And then similarly, if you go into the next slide, ICHRA arrangements have been, quite a talking point, I would say, the last couple years as we've seen commercial insurance skyrocket. A lot of employers have looked at alternative solutions, and ICHRA has been one of those options that has been more competitive in certain markets. Maybe a little bit more difficult for multi-state employers where you have employees in a certain part of the country where individual plans are not competitive. But we've found, in the Midwest here, it's been a more competitive ICHRA market and has been an avenue for employers to save money compared to that fully insured increase. One of the things too, as we talked about Medicare education earlier in the presentation, with these ICHRA arrangements, it kind of helps with an aging population because there are no individual plans for people that are over age 65. So if you're an employer that wants to offer an ICHRA, your portion of population that is over age 65 has to get onto Medicare. And typically they now become your lowest cost employees when it comes to this ICHRA offering. So it stands for Individual Coverage Health Reimbursement Arrangement. And the way that it's set up is that you're essentially funding an HRA for an employee to purchase an individual plan, typically through a platform that's going to give them visibility to the options that are available to them in the market. This has created significant savings for a lot of employers that have a younger population compared to maybe what that group renewal has been. But there are caveats where this doesn't work for every employer based on their employee population, that multi-state status, having dependents in other part of the country. So really, when it comes to considering ICHRA, we want to focus on the pros and cons. Pros are being predictable to the employer from a cost structure, the plan designs for employees as well. Employees get to choose their own individual plan, so that's one of the benefits in terms of freedom of choice. There's no participation requirements. There's tax advantages with the reimbursement structure and the HRA, and making it a pre-tax benefit funded through that HRA and platform that you're using. And typically it can be a lower administrative burden compared to a group plan, especially maybe even a self-insured plan. But some of the cons are that employees must shop their individual plans. So they have to choose. You can't choose for them or tell them they only have one or a few options to choose from. There may be additional education required because it can be confusing to people that are having to purchase an individual plan for the first time through a potential platform. But then as a potential large employer, you still have to make sure that you're meeting those ACA affordability rules. So very important to make sure you structure it in a manner where it still remains affordable. And then kind of what I've already mentioned, there's potential network disruption. A lot of individual plans have more narrow networks, don't have national coverage, and may not work if you have dependents that live outside of the state that you live in. And then, with an IRS class ruling, it restricts mixing group and ICHRA plans together. So you can't have a group plan for a certain portion of your population and an ICHRA plan for another portion of your population. You kind of have to be in one bucket or the other, but it's worth evaluating if you've had volatility with your commercial plan and may not have the risk appetite to potentially self-fund and are looking for a strategy of savings or controlling your cost a little bit more effectively.
Yeah, this one is, again, it's been a big one, and it's trending. We've seen the last year or two that even larger employers have looked at this as a viable option, right? When they see potentially, 25-30% decrease in costs. Some of the cons, right, can be worked out as well, that maybe now employees will get almost near free healthcare because the amount you're going to fund through the HRA, but they have higher deductibles, higher out of pockets, but so one can kind of offset the other. But it's definitely something we have seen a significant increase in employers taking a look at it.
We have a question pop. We had a question pop up. Would it make a difference if we are located in a rural area?
Good question. Not necessarily. So let's say you're in North Dakota. So the plans that would be available to you would be by zip code. But what you have found is your employees then would have the choice between Sanford, Blue Cross Blue Shield, United Healthcare, Medica. So the rural areas still have choice, some more than others, right? So there are only 2 carriers that compete in that geographic area versus maybe in Fargo there's 4 or 5. So it could vary by zip code, but we have found that there's still pretty robust competition even in those rural markets.
And let's say, you have your employee population all over, North Dakota, and, Fargo is a little bit more competitive than, Bismarck. You can, in terms of making sure that contribution is affordable, you can structure it where in that higher cost area that you're contributing more to that employee's potential plan option, especially if you're a multi-state employer, because that's where you may have to do some different contribution strategies for employees that are in a different market where those insurance offerings may be equal to or greater or less in some instances.
Any other questions?
We had more of a comment pop up if you wanted to read it and if you wanted to provide any.
Sure. One thing you mentioned is direct to employer healthcare. Not mentioned. Healthcare, our self-funded employer group insurance plan just added this to save on routine medication management, walks type in-type healthcare. Kavira, our plan added it to decrease claim costs, but it would work great in conjunction with an employer offered high deductible plan to cover those visits for employees. Kavira Health, the one where we're on, offers health calls and remote visits that are a copay and co-insurance free to the employee, making care more accessible and affordable. Health address smaller issues for employees before they are big ones. Yeah, that's a great comment. That is also something that we it is starting to move into the North Dakota marketplace as well, and there's also other options in the market as well. Nice Healthcare is also another one that we've partnered with, but that is a way to really allow your employees to have access where the provider would come to their location, their home, for primary care visits, prescribe medication. They can do imaging, those types of things, and it really runs it outside the healthcare plan, and can save on dollars as well, because it's a capitated plan. It's a flat amount for those services versus, running it through the normal healthcare system, which generates larger costs. I don't know, Chase, anything you want to add to that?
Yeah, I think, those are great options to consider. Obviously, there's telemedicine options too. and depending on where you are and if it's a serviceable area, you may be forced to use telemedicine. But any sort of situation where you can redirect healthcare away from the group plan is going to create savings and a help with a lot of that general utilization. These types of models don't necessarily treat cancer or perform surgery, but it can help with that overutilization that may be occurring on your plan. One of the important considerations is to look at the framework of these type of offerings and who is doing the treating of care, and then also making sure that it is HIPAA compliant.
Okay. And then last but not least, physician engagement. So in other words, we call it under our population health management program. And so this is more of the more difficult part of healthcare, right? How do we control behavior? How do we control spending with employees related to their health, right? So we are big proponents of incentivized physician engagement, and for many reasons. So is incentivizing your employees through a monetary incentive, through premium incentives, that they seek out a primary care engagement once a year, right? And as you can see in the statistics in this slide, that those who engage a primary care doctor every 12 months, you can see inpatient admissions, ER visits, and all these categories, the costs considerably go down, right? And so it is something that can easily be put in and build in some incentives into your healthcare plan to promote that. And that's not saying too that when folks that do go in, you're going to catch things early, right? So I maybe have an ailment that I haven't been diagnosed. I'm walking around, I don't have any symptoms. And then when I do have symptoms, I go in and I have stage 2 cancer, or, which could have been caught at stage 0 or stage 1, and across the spectrum as well. So it's something that as an organization, we are very passionate about, and again, and can see the results when you do put in an incentivized physician engagement program, that over a 2 or 3 year period, you are going to see a reduction in healthcare costs across the board.
And that's where using your data effectively becomes very important. Whether it's, analytics like what we can provide in terms of our 3D, or using a third-party platform that is providing you analytics. It's using the data to help drive decisions and control costs better, short-term and long-term.
Great. And I'll just say 5-minute warning, guys, out of respect for everybody's time. If there are any additional questions, please get them now. Otherwise, we can talk after the call on a more intimate basis as well.
Sure. Yeah. Okay, we'll wrap this up. This is our last category as well. So this is just another slide that confirms physician engagement. And this would be a typical employer. If you look at the bottom here, where they're least compliant, you can see this particular group, right, in these categories. Colorectal screenings, they're at 25%, and in the middle as well for their tests over 50. And then the last one as well, members that have received a preventive care visit in the last 12 months, that 36%, and what our book of business average is as well. So this is very typical where we see employers. So the idea is we want to, again, incentivize those that are in that non-compliant category to go in and seek that primary care engagement. And with that, that's all we have. I know it's a lot of material, and we want to run through, the spectrum. But if, again, as an audience, if there's anything, any of these in particular, you'd want to do a deeper dive, looking at your data, your situation, certainly reach out. Or if you'd like to see a webinar, focused on specific categories as well, we can plan that for the future as well.
Yes. Thank you all. As mentioned at the beginning of the call, if you weren't on, Brady Martz has a strategic alliance with USI. We're proud to do so. They're extremely high end, and yeah, you could either reach out to myself, write to USI, or just reach out to your relationship manager. I know many of you will be meeting with your CPA over the next couple months. If you have health insurance concerns or questions, please let them know while you're meeting with them, and we can attack something like this potentially after tax season too.
Thank you, everyone.
With that, we will end the webinar. Thank you, everybody, for attending. Have a great rest of the winter and into spring.
Thank you.